Hi, I'm Dr. Damien Gatinel from the Rothschild Foundation Hospital in France, in Paris, and I'm very privileged today to be with Susana Marcos, who deserves no introduction. Susana, welcome. I'm very happy to be here with you. And first, I hope you're doing fine in Florence, and you recently moved to Rochester after being for a long time the director of the, Institute of Optics in Madrid. So how's life in Rochester?
Yeah, it's great. I moved from the Institute of Optics in Madrid to the Institute of Optics at the University of Rochester, New York, and Center for Visual Science and the Flamma Institute. And it's great to be in a place where optics and ophthalmology go hand by hand. So very happy to be there.
Yeah, and that was the flavor of the session today. I think it was a session where really the importance of optics was there, and also people debated of the clinical relevance of all the optical fancy simulations we are doing. So what is your opinion on the debate, or let's say the approach of the simulation versus the experimentation, the testing?
Yeah, I think this is a great question, and I think we're coming up with techniques that allows us for a better optical simulation in the first place, and then optics is also being used for visual simulation, so kind of a virtual surgery where you don't need to implant the lens to really feel how the world looks like through a lens. And I think those are very important because there's like two stages, right? So first you have to select the lens, the intraocular lens that is based on the coupling of that lens with the optical quality of the eye, and to perform a good biometry. And I think we have now the OCT, quantitative information. So your presentation had really great modeling where you were like simulating optical quality and therefore focus with the designs of intraocular lenses. That can be certainly expanded with using individual information of corneal topography and biometry. And I think this is where the intraocular lens selection should go. I think probably moving out from the standard IOL selection formulas to something that combine this breadth of information on the lens and on the geometry and biometry and 3D information of the eye. And I think coupling that with artificial intelligence is the next way. This is still optics, right? It's like simulating the optical quality, the retinal image quality. Next step is visual simulations, which is what the visual simulators allow us to do.
Yeah, so in other words, we would move from a simple IOL power prediction formula to a more comprehensive IOL power, optical quality, and visual performance formula, right?
Yeah, so that's the combination of more sophisticated optics and sophisticated eye modeling, and then really also putting the neural performance in the equation, right? It's not only to improve and optimize the quality of the retinal images, but to optimize or introduce the patient's preferences and do that binocularly. I mean, there is a number of binocular factors that take into account, and the possibility of testing which lens can go in one eye and which lens can go in the other eye, and really how is visual performance connected to this image quality that you simulate from the eye models, and how the patient really sees and perceives the world through those lenses.
You have an expertise in chromatic aberration. I remember I met you more than 20 years ago at ARVO, and I was impressed because you had co-authored a Nature paper, I think,
Yes.
right?
Mm-hmm.
Yes, it was about the importance of chromatic aberration in comparison to monochromatic aberration. So today we mainly discuss things in the kind of monochromatic approach, although your simulation with the Gecko SimVis makes the eye in the natural polychromatic environment. So my question is, how much importance should we give to the polychromatic properties of these IOL? It's still debated.
And I think this is a phenomenal question. And of course, I mean, you've developed the trifocal lenses, and when it comes to diffractive optics, chromatic aberration is actually even reversed in at near, for example. So you can really control chromatic aberration, and this is a prime example where I think optics and the neural performance need to be combined. In that Nature paper that you referred to, we found that coupling of the monochromatic and chromatic aberrations are actually the protection of the eye against chromatic blur. Now with visual simulators, we can actually test for that, right? Because we can cancel the monochromatic aberrations, we can play with the chromatic aberrations. What we're seeing in the visual simulations is that in a way there's also some neuroadaptation to the chromatic aberration. So it's not only the coupling with the optics that benefits the presence of these interactions, but also the fact that the same type of blur in blue is different than in green. So we believe that there is also some type of adaptation to chromatic blur. Yeah. But yeah, certainly something, one aspect that we need to take into account, because we see and live in a polychromatic world.
Yes, because I hardly sometimes see patients that complain about any chromatic aberration, although they have a very a complicated surgery leads to a tilted or dissented IOL. And IOL is strong in terms of power, so there would be a lot of prismatic effect expected, but they don't. On the other hand, patients with rainbow glare, which is different mechanism, but where there is a chromatic spatial spread, they see it very well, and they are annoyed by it. But again, in those monofocal or multifocal IOLs, there's not so much chromatic impact, I would say, even in complicated situations, and that's always puzzling to me. Because I've seen lens half dislodged, so it was basically a prism in the pupil, right, of 20 diopters or more, and the patient would see, of course, the world blurred, but not without any fringe, as you would see on those prismatic Newton-like depictions. So.
Yeah, and I think this is, again, another example where you can make predictions, optical predictions, and the more you put about the biometry of the eye and tilts and decentrations, because everything is very well balanced in the eye. So what happens when you disrupt this balance optically, and also what happens perceptually. And I think that was kind of the spirit of the session. I think really advancing into understanding the optical image and understanding the optical properties of the lens, plus the lens being implanted in the eye, and then understanding the coupling of this retinal image quality with perceived vision.
So it is very exciting that we can test the optical lenses that your device, I'm referring to the headset, the Geeko SimVis simulator, especially when we have patients that come for more a refractive surgery, cataract, than advanced cataract. And I think that the colleagues who use it seems to find a lot of interest in that. On the other hand, in patients with severe cataract, how would you, and you said this still has a value, but how would you rate this value? I'm inclined to believe that if you have a very nuclear cataract with myopic shift, already you have a multifocal eye. So sometimes to me it's already a simulation that multifocality may be well accepted, especially when the patient tells you, now I don't see well at distance, but I read and without spectacles, and I'm happy with that.
Yeah, there's two stages there. One advantage of the SimVis Gecko is that because it works under the principle of temporal multiplexing, it kind of bypasses these opacities. So we are delivering a multifocal lens or a multifocal image on the retinal plane. Of course, you still have the scattering. So what we found, and there was a range of opacities that is still allowed for that the patient could rank the quality of different lenses. But you're absolutely right. I mean, you have like a clear lens, then you can really see the full benefit, and not only a relative benefit of one lens versus the other, but really a simulation of how the world really looks like through those lenses. And this is where our validations with many different lens designs and lens types, where we measure, for example, the through focus visual acuity with simulation preoperatively in presbyopic patients, not cataract patients, and then we compare that with the through focus quality in implanted patients. The through focus performance is not only the same in relative values, but also in absolute values.
So in conclusion, I think what's important today is to realize that we have an incredible volume of simulation because of the advances in micro-optics, computer power, and also we have a bunch of new lenses on the market that we are very happy to analyze. That's what we do in my group, but this is just a part of the story, and the acceptance and the actual vision through these IOLs with retina and then the brain behind it remains very important.
Yeah, and I would say that really, the power is in understanding what's happening. So you really need to understand the principles of the lens, the optical quality of the lens, and then that will help us, along with us visual simulations, to really understand how the patients are, tolerating those lenses and seeing through those lenses.
Thank you very much, Susana.
Thank you, Damien.
And have a
pleasure.
great meeting.
You too.
Thank you.